So today we're going to take a quick look at the two tracks that most people are concerned about, which is the CMS report to the government track, and then also the HEDIS report to the payer track. We're going to talk about QRDAs and make sure everyone knows what they are and why they're so important. We're going to talk about certified EHR technology, which is what that stands for, or CERT. And we'll talk about some of the things that MyHIN is focusing on and putting into production today. Okay, so what are they? We're trying to quantify healthcare, and there's a national shift moving from process-based to outcome-based measurements. So not just, did you do the test on the patient, but how are they doing? Are they healthy? Let's take a quick look at an example. This is one of the most ubiquitous measures that you are all familiar with, most likely. And so this is adult hypertensive patients, 18 to 85, and at their most recent visit, did they have their blood pressure under control? So we'll come back to this example a couple times today. So who benefits? Patients, providers, and payers are all working very diligently to make sure that healthcare is improved, and quality measurement is a big part of that. And at the end of the day, we're trying to achieve the triple aim, which is to improve outcomes, improve patient experience at a lower cost. Why quality measures? Again, we're trying to achieve triple aim. It is essential to this transformation that we're seeing from volume-based to quality-based care and capitation payment models, alternate payment models from CMS's point of view. It can help identify common pitfalls that we see in care delivery and try to address those. So people can come up with new measures that will measure a certain pitfall and then improve those. And of course, it facilitates improvement. And if we get down to this vision of real time, it can even help while the patient is still in your office or in your building. So what are some issues we're seeing today? So increasing burden. As we move from volume-based, we need to make sure that we don't burden the providers too much. In the last decade, we've seen an explosion of quality reporting requirements, and we need to make sure that doesn't get too overwhelming. Lack of standardization, when we're talking about pulling data out, moving the data, calculating it, and then submitting it. There are some standards out there that are becoming strengthened, and we're going to talk about some of those. But right now, it's not really standardized at all. And for those programs that provide feedback, and it's not all of them, there's often a huge lag time for the performance feedback. And in the case of payers and HEDIS especially, this can be 3 to 6 months or longer, and it's simply not actionable, and we need to work toward getting it down to real time. So the two main tracks that our stakeholders in Michigan have been focused on, and I think nationwide, are report to CMS programs, right? Medicare and Medicaid. These include programs like Meaningful Use, MIPS, CPC Plus, and others. And I want to stress that Medicaid Meaningful Use program is still up and running as normal. It is not affected by MACRA legislation. Now, the formats that we use to report to these, right now there has been an option to do manual attestation, which is you log into a portal and you type in the numerator and denominator numbers that your EHR vendor reports to you. In my opinion, this is not going to be sustainable moving forward for much longer, especially under MIPS, where your numbers are actually going to start impacting your payments, and it's just going to be too tempting to fudge the numbers, and we need to move away from the manual attestation as quickly as possible. The other format is QRDA, which we've really tried to rally around as MyHIN, and I think we should as a state. The other track is reporting to HEDIS and the payer incentive programs, which there are many of, and they're very great. They're also typically based around some of the core HEDIS measures anyway. And the way you get the data to the payer, it's called supplemental clinical data, it varies payer to payer. And this is kind of the origin story of PPQC, which Joe Neller will talk about later. But each payer typically requires a different format of how they want to receive that data in some kind of proprietary CSV file or some various other formats. So let's talk about QRDA, just to make absolutely sure everyone knows what it is. Spoken to quite a number of stakeholders and people working in hospital systems that have never even heard of it. So I want to make sure we all know. So it stands for Quality Reporting Document Architecture. It comes in two flavors. Category 1 is patient-level data elements, and we're going to see some examples of those elements on the next slide. And Category 3, which are calculated, aggregated measures for a particular physician. Health Level 7 International, HL7, came up with these specs. They're headquartered in Ann Arbor, just down the street. And basically, the Cat 1s at least contain what the payers want in their proprietary specs as well, which is who's the patient, who's the provider, diagnoses, procedures, labs, lab results, those type of things to calculate all these measures. But most importantly, QRDA's establish a national standard, not just statewide, but national, in which we can exchange clinical quality information. So just coming back to that example of controlling high blood pressure, I logged into the measure authoring tool. This is going to be kind of hard to see, but these are some of the data elements that are required to calculate that measure. So another thing about Category 1 files is that they only target specifically the data elements necessary for that particular measure. They're not trying to take all your data out. There are people concerned about that. So each element is identified with an OID, an object identifier, and again, diagnoses, labs, patient demographics type of information. So certified EHR technology. Oops. Most people are using certified EHR technology. That's what this graph shows. If you can't read the numbers, basically in the yellow is the percentage of office-based physicians who are using a certified EHR, and it's at about 78% as of 2015, and one can only assume that the trend is continuing upward. So most people are using an EHR that is certified. And there's a process that you have to go through to get your software certified. And part of that is to demonstrate the ability of your software to create QRDA files. And as we move from the 2014 edition to the 2015 edition, this gets even more stringent. And we're really at a point where your EHR should be able to make QRDAs. Oh, and the last bullet there, this is being taken very seriously by the government. Just a few days ago, Department of Justice came to a settlement with a major EHR vendor to the tune of $150 million to settle issues that they had certified to certain abilities of their software, but that turned out not to be true. So this is kind of a sign of how seriously the government is taking this. And if you say you can make QRDAs, you really should be able to. So through reading all these hundreds and sometimes thousands of pages of final rules, this was one of the passages that really stuck out to me. And I spoke with Dr. Larson, and he said they worked very, very hard to get this into the 2015 edition final rule for certified EHR technology. So forgive me as we read this word for word. A system user will be able to record and export individual patient-level ECQM data formatted to the HL7 QRDA Category 1 at any time the user chooses for one or multiple patients without needing to request support from a developer to operate. The ability to export ECQM data will serve two purposes. First, this functionality will allow a provider or health system to view and verify their ECQM results for quality improvement on a near real-time basis. Second, the export functionality gives providers the ability to export the results to multiple programs, such as those run by CMS, states, and private payers. I added the bolding, but I think that's a really powerful statement, and this is in 2015 edition Certified EHR Technology Final Rule, and that is becoming mandatory in many programs as of January 1st of 2018. So your EHR should adhere to this statement in January. I like to include this slide that came up at a ECQM Affinity session last year, and I'll just highlight the bottom rows. The reporting format that we're really trying to move toward is QRDA Category 1, because it's got patient-level information that you can do a lot of interesting things with. And again, we're trying to move toward real time in terms of reporting frequency in order to enable improvement. So no MyHIN quality presentation will be complete if I didn't go through the animation for what we affectionately call our skimmer service. This is the Clinical Quality Measure Reporting and Repository Service, and this is something State of Michigan Medicaid Incentive Program kindly asked us to build for them. And this is all about receiving and processing QRDA files and getting them sent to multiple potential endpoints. So there's a little bit of animation here. Eligible providers, eligible hospitals attach a QRDA file, whether it's Category 1 or Category 3, to a direct secure message from their HISP. This is another great way to utilize direct, which is also required to be provided by your EHR. You send it as a payload. We pick it up. Our little catcher guy is called Mitigate System. We strip the QRDA file off of the message, and we do a few things with it. We validate it, make sure it adheres to the CMS implementation guide and the HL7 specs, and then we send a feedback message back to your sending direct address and said, we accept your message or we reject it for the following reasons. Let's work with your vendor to improve that QRDA. In the case of Category 1s, we can store them temporarily in order to eventually roll them up into a Category 3, which is that calculated result, which is what the state of Michigan wants at this time. And then we can send the end result file to the state of Michigan data warehouse in the case of Medicaid meaningful use, and also to other programs such as MIPS. MyHIN is now a qualified registry for MIPS, and we're looking forward to the API that CMS is going to release that's going to automate even further that process to that portal. So I want to shift gears abruptly to the other track, the other side, which is the HEDA side. And this is a spin-off of the Skimmer project, and this is PPQC, Physician Payer Quality Collaborative. So Joe Neller is going to talk about this in depth later. You'll notice I updated some of the icons, so I hope some of you orgs appreciate that. This basically shows the physician organizations gathering up their all-payer supplemental data files. And this is that proprietary CSV pipe delimited file that we agreed to standardize on in the short term. In the longer term, we did achieve group consensus that we want to move toward QRDA. But for the meantime, we have this kind of agreed upon spec. And big announcement was made yesterday by John, but I just want to reiterate that as of yesterday or 2 days ago, we have released the first split files to the payers, and that's a huge milestone for us, and I think we should all be proud of that. So now we basically receive an all-payer, all-patient supplemental data file. We split that up based on our ACRES service, Active Care Relationship Service, and give it to the individual payers. And so that's happened this week. So what are we going to do in the interim? So I mentioned that we do want to transition the PPQC kind of HEDIS data flow to QRDA as we move forward, but we're not quite there yet. So this is a sneak peek. We at MyHIN are developing or have developed early kind of prototype software that can convert between these formats, between QRDA Cat 1s and this all-payer supplemental spec that we all agree to in the PPQC group. This is early. We're still going to be testing, and there's going to be some certification that needs to go on. But this is very exciting, and this is going to allow time for the payers especially to learn about QRDA and get familiar with that and be able to process that. And eventually, we'll be able to reel this back and just have QRDA be the format that we rally around. So I know Dr. Jeff Eastman is going to be speaking later about some of these upcoming standards, so I'll just plant the seed here and leave it. We've heard a lot about FHIR in the conference so far, the Fast Healthcare Interoperability Resources, and this is basically going to be a way to query. And as applied to quality, this could be a very interesting way to surgically query a system for those particular data elements that we saw an example of and pull them out. If you want to get really fancy with it, you can also build in some of the calculation logic into the query itself. But that's an advanced strategy. We'll let Dr. Eastman talk about that. And then also CQL, which is clinical quality language. This is going to replace the logic layer of how we calculate ECQMs today. And this is going to be rolling out, and it's going to make the calculation piece a lot easier. It's going to be machine readable. There's not going to be as much room for interpretation on how you calculate. So what are the goals with what we're doing with our skimmer service, which is now in production, and our PPQC pilot, which is gaining traction and finally moving data? We're trying to, again, reduce burdens on providers. We're trying to automate as much of the workflow as possible. We're trying to decrease labor costs for pulling the data out once we get that flow going and hopefully automated messaging coming into MyHIN's skimmer service. We're going to do some improvement opportunities, right, with moving toward real-time feedback where the physician can see their quality scores and how they're doing on an ongoing basis, on a per-patient basis, and potentially even improve the care while the patient is still on site. And finally, we want to standardize data sharing as much as possible by rallying around QRDA as the national standard by which to extract and move quality data. So we want to make sure that our solutions are scalable not only across the great state of Michigan, but also across the nation. So I think that's it for me. I hope I stayed in time. We have 2 minutes for questions. 2 questions.
If there were 1 minute, that's perfect. Any questions? This is a workshop. There should be lots of questions.
I have a question. Currently, as a health plan, we receive our data from our claim system, and then we receive data from our claim system. We also collect data from our providers separately. Is MyHIN going to eliminate some of that, where we'll get our data from you instead of from our providers?
Right. So Joe Neller's going to show you this, what we call the spaghetti diagrams. But basically, they depict the one-off connections that right now you're having to make with each physician organization or even sometimes offices to get that supplemental data. And it's very inefficient. And what we're trying to do is eliminate all that spaghetti and have them submit one file to one centralized place at MyHIN, and then we'll use your ACRES file to give you your patients from that big file. So this is going to improve a lot of things, and as this matures, hopefully it gets to the point where you can start turning off some of those other pipes that you're maintaining.
Right, great.